Assalamualaikum. This is Amplog. I hope you are all doing well. I am Dr. Mohammad Ali Rabbani, Assistant Professor of Anatomy, and today, inshallah, we will continue with our lecture series of lectures for head and neck. Today is the second out of three lectures on the topic of neck. The topics we are going to hit today are the fascia of the neck, all the structures that are present beneath the skin. They are making the superficial fascia, the deep layers, all the fascia, their attachments, the structures embedded within them, and all that. Then, what are the spaces that are made between these fascia? Facial spaces of the neck. Then, the topic is triangles of the neck. Here, our focus will be, inshallah, on the boundaries of the triangles and the contents of the triangles, but I won't go into the detail of all of them. For example, in the anterior triangle, there is presence of thyroid gland, so that won't be our topic for today. But we will discuss how each and every one of the triangles is formed and list their contents. We will go into the detail of the structures that are mentioned here. We'll mention the cervical plexus. It will help you get a better understanding of the muscles innervation, the muscles that we discussed in the previous lecture, and the sympathetic trunk. That inshallah we will be done with this topic also. So for the neck, our the next session, the third session of the neck, we will be majorly focusing on the vessels, the arteries, the branches, the veins, the lymphatics. The viscera of the neck, there are separate days system wise. So there is a day for the digestive system. On that day, we will start from the lip and go all the way to the esophagus. On that day, we will discuss oral cavity, tongue, pharynx, and upper part of the esophagus. Similarly, this I'm talking about this because pharynx is a component of the neck, and you may not feel that I'm leaving them out right now. Similarly, larynx and trachea are the components of the neck. I won't be discussing them in these three lectures of the neck. Inshallah, as we move on to the respiratory system, we will move from nose to trachea, nasal cavity, paranasal sinuses, nasopharynx, down to larynx and trachea. And in the respiratory system, inshallah, we will discuss a little structure, the thyroid. I'm deliberately leaving it out right now because till now we have not discussed a lot of the structures surrounding. Most of them include the vessels, and we have not discussed the structure around which is wrapped, that is the respiratory system. So we will move it then. If there is still any query, any request, you may mention it our own page, and please do follow us on YouTube. Inshallah, we will be uploading more of this stuff. Let's start with the first topic, that is the fascia of the neck. Okay, what are the fascias of the neck? Cervical fascia. Let me be a little biased. I have been using this picture of Netter's Atlas for teaching the fascia. I'm very biased. I usually say that read whatever the atlas you uh, like and whichever one clicks to you. On this one, I'm very protective of it. Do open the books and open the Netter's Atlas and look at this picture. It has a beautiful color coding and it shows you where the different fascias present. Okay, so the fascias, these will be the two pictures I will be following in the slides, in the upcoming slides. Then there is this horizontal section. This horizontal section is taken at the level of thyroid gland. and level of seventh vertebra. And then there is a picture in this sagittal section. So there is a fascia and the different color schemes. Inshallah, we will go through them one by one to break them down, and I hope so I will be able to make your things easier rather than difficult. Please let me know where you are not following me, where I'm losing track of you. Inshallah, I will try my level best to get back to you. The superficial fascia. On this particular picture, it is shown by the gray line that is surrounding the outside. Just below it, the skin is the gray line. This area, this is the superficial fascia. It is like the rest of the body. It is the fascia that is present between the skin and the deep fascia below. It is filled with loose connective tissue filled with fat. This is similar to all of the body where this fascia is present and the fat is deposited here. It is more defined in the trunk, in the abdominal region where it is membranous and fatty layer, but there is no such demarcation in the neck. Last week, you all had, I hope so, you have enjoyed your Eid al Azha. You must have seen a lot of animals being sacrificed and the skinning of the animals. The skin, the hide which is being pulled consists of the epidermis and dermis, and the fascia through which the plane is made, through which the butcher makes a plane to separate the skin from the rest of the body. That is, he is acting in the superficial fascia. That is the subcutaneous tissue, that is the superficial fascia. So it surrounds all of the neck like a circle. It contains fatty tissue, and as a person goes increases his weight, the fat deposits in the neck, and the neck may tend to go thicker due to the deposition of fat in the superficial fascia. It contains, interestingly enough, it contains an embedded muscle. We discussed it yesterday. That muscle is platysma. In this particular picture, it is shown by this gray line. This is the platysma muscle. We talked about it yesterday that it is very unique in this sense that it originates not from the muscles but from the deep fascia covering the thorax. The deep fascia in front of the back major, deep fascia on deltoid and back of the spinal scapula. And this fascia, apart from it, contains all the things that are usually present in the subcut tissue. What structures are present? These structures contain the cutaneous nerves, superficial veins, and the lymphatics, including some of the lymph nodes. So these are the similar headings as you have read in all of the other regions. So cutaneous nerves. Cutaneous nerves includes the four cutaneous nerves, all the same cutaneous nerve we did yesterday in the skin part of the neck lecture 1. There were four nerves around there were nerves on the back. That was the greater occipital nerve that was going all the way up to the um, occiput region, and then below there were segmental posterior rami of C2, while occipital there was C3, C4, C and so on the back region. In the front region there were four nerves, all of these emerging from the posterior margin of the sternocleidomastoid. The one going upwards were greater auricular and lesser occipital. Greater auricular was in front of the ear, angle of the jaw, or lesser occipital was in the back of the ear. Transverse cutaneous was moving across and moving to the front of the neck, chin to sternum. This area is supplied by this, and supraclavicular nerves was moving downwards from the point of its emergence from the back of the sternocleidomastoid, and it was spreading like this to the front of the pectoralis major up to the second rib and the angle of Lewis, and back of the upper half of the deltoid and back to the spine of scapula. So it is almost the same region as we discussed about the origin of platysma. I discuss these regions in these nerves in the skin, but I will also discuss by the end of this lecture when we discuss the cervical plexus. Superficial veins. I'm just going through the names right now. How are these forms? What they join? What the veins are formed when the two of them join? What are the tributaries of each of the veins? we will discuss in tomorrow's lecture, inshallah, when our major focus will be the vessels. So just going through the nerves, it consists of posterior alveolar nerve, posterior division of retromandibular nerve, that is right here, posterior external jugular vein, transverse cervical, suprascapular, anterior jugular veins. You have seen the external jugular veins in the lecture yesterday. Inshallah, we will go through them also. Lymphoid nodes, just go through the names right now. Again, this is the topic of tomorrow's lecture. It contains the occipital and mastoid nodes. In the tip of the posterior triangle, we will go through that triangles today. And then there is a amount of fat. Deep fascia. Everything below this, everything beneath this is the deep fascia. In this particular picture, everything in color is the deep fascia. It supports the neck. All of the muscles are like, it is deep fascia, like all the deep fascia you have read till now. You have read about the fascia lata of thigh. You have read about the fascia covering the limbs, upper limbs, and so on. Just like that, this deep fascia is very tough, non-relenting, and it is circling the neck like a very non-elastic socks. It does not allow the neck to expand up below point. It keeps all of the muscles, it keeps all of the structures within the confined space. And because there are multiple layers, you can see in the red there is outer layer and the other colors, there are multiple layers. So it keeps the things limited to those areas. So this is prevertebral fascia in the orange shown. A pus hair will remain in this space unless and until the fascia is ruptured and allows it to come into the next space. So that is how the structures, the bleedings, the infections there remain compartmentalized. Not a natural function, but for the surgery's perspective, they gives the plane for dissection during the surgery. When you have to reach a particular structure, you tend not to go through the plane. You don't cut the planes unnecessarily. You remain between the fascia. You remain between the layers to reach the structures. That way, if you remain in this plane, that way you will not damage any structure that is present in the other compartment. The natural function is the neck is continuously moving. As long as you are alive and healthy, you are continuously moving. But even if you are not moving, you're swallowing, the structures are moving up and down, you are having breathing movements. So these help the gliding of structures across one another. So these are the structures. So before going into that, we will be studying in three major layers. First one will be the one that covers the whole of the neck, the one that is shown in the red here. That is the investing layer of deep cervical fascia. Let me quickly jump through the slides. I think I misplaced the slide to this one. Yes. So this is a summary slide. You may get a picture for it. Uh, let's see which are the layers that you will show. So these are the three major ones. The one that is surrounding whole of the neck, just like the facial lata of the thigh, that is the investing layer. It has invested whole of the skin. The one in the orange, that covers the vertebral column and the muscles that are around it. Vertebral column and the muscles that are around it. This is known as prevertebral fascia. And we are left with this, the one shown in the blue color and the one shown in the purple color and the one shown in the green color. I will talk about them separately, but in most of the books, the book that you read, the Snell, it gathers them, all of them together by the name of pretracheal fascia. So it is basically covering whole of the viscera and the surrounding muscles. It is thyroid, trachea, esophagus, and the nerves and the things that come between them. These are the three major ones. Then we are left with the one that is shown in the green. It is the carotid sheath. There is a little debate, but the major consensus is that it is not an independent facial sheath. It is made by borrowing the parts from each of the sheets around here. Like if you look at anterolateral aspect, it is made up of investing layer. from the posterior aspect, it is made up of prevertebral fascia. On the anteromedial aspect, it is made up of pretracheal fascia. So it is simply a very loose connective tissue, areolar tissue that is reinforced by the surrounding fascia. Okay, let's dive into them one by one. Investing layer of deep cervical fascia. Let's start from here. It encircles the neck, equivalent to deep fascia everywhere, and when it forms a neck, if you follow the red line, you may be able to see that it is actually investing two pairs of muscles. The one that are present here, the one that are present here. These are the exact two muscles that are supplied by the spinal root of accessory nerve. Sternocleidomastoid and trapezius. So these muscles are not present inside, not present outside the fascia. These are embedded within it. When we come to the anterior border of sternocleidomastoid, this fascia splits, and between the two slips is present the muscle. So it splits to cover this muscle, and this is a very, very important MCQ point. Very, very important questions. Which muscles is it surrounding? Then the similar question is about the glands. It is surrounding two salivary glands, the two larger ones, the parotid gland and submandibular gland. And let's talk about the attachments. It is attached. You in the first lecture of the neck yesterday, we discussed about the extents of the neck. On the upper end, we discussed the attachment right here, the ring that is formed by the neck. So these are the attachments of the upper end of the investing layer of deep cervical fascia. Start with an additional point, that is the hyoid bone right here. Then it is attached to the whole of the inferior border of mandible. From here, it jumps to the mandible mastoid process. It goes to the superior knuckle line, and it ends at the external occipital protuberance. So this is the upper attachment of the sleeve of the investing layer of deep fascia. You may notice if you move your finger from side to side, from the angle of the mandible to the mastoid, there is no bone. The fascia has to jump from this point to this point. When the fascia is jumping from the mandible all the way to the mastoid process, there it does not jump as a single fascia, it splits, and the two layers, the one that is nearer to the skin superficial, it's called parotidomesenteric fascia. We will discuss more of it in the face region and the parotid region. And the deep part, that the both of these parts, they enclose the deep and superficial part, they enclose the parotid gland and the submandibular glands, and the deep part is involved in the formation of the stylomandibular ligament, to be discussed in the temporomandibular joint. Okay, below it is attached to the lower end of the, if we see from the front, what was the lower margin of the end of the neck? Jugular foramen, jugular notch, sorry, clavicle, acromion, spine, and back. But if you go through them, it has a muscle attachments. Let's start from back front. The trapezius, the spine of scapula. The attachment at the spine of scapula, it's not independent. It is, again, it has split to cover the trapezius, and it is attached with the trapezius to all of its attachment that includes the spine of scapula, acromion, and lateral one third of the clavicle. Then medial one third of the clavicle and manubrium is attaching with the that it is attaching with the this sternocleidomastoid muscle. So there are two spaces left. The space between the two sternocleidomastoids, the jugular notch, and the middle one third of the clavicle. At the lateral one third of the clavicle, it has attached with the sternocleidomastoid, and the lateral one third, it is attached with the trapezius. So in both of these spaces, it remains two layers. So when it is the jugular notch, the two layers are shown right here. When it is attaching to the manubrium sterni in the jugular notch, thus two fascia attach it forms the suprasternal space of Burns. And here it contains a few structures, mostly internal jugular vein and its communicating arch, and a few point of insertion of sternocleidomastoid along with some lymph nodes. And then there is a space between the sternocleidomastoid insertion and the trapezius. And here the again space is formed. This space is pierced by external jugular vein, and the two layers formed at mid clavicle area. The posterior one, it forms the sling for the two bellies of omohyoid. So this is about the facial attachments, facial layers, and here I missed this one. So it in addition to enclosing the two muscles and the two glands, it forms two spaces, suprasternal space and supraclavicular space between its two layers. It forms the stylomandibular ligament, and it forms the sling for the two muscle pulleys. The two muscle pulleys we discussed in the neck, first lecture of the neck, the between the two bellies of digastric, the one between the two bellies of omohyoid. Both of these are formed by the investing layer of deep cervical fascia. So this is all about the investing layer of deep cervical fascia. Moving to the next fascias, let's follow the color coding of the next picture here. This is the fascia that is covering the infrahyoid muscle, that is infrahyoid fascia, also known as muscular layer. If you remember from the previous lecture, from the yesterday's lecture, it might come into your mind that the infrahyoid muscles were arranged in two layers. In front, there were sternohyoid and omohyoid muscles. In front, there were sternohyoid and omohyoid muscles. When we removed them to look beyond, when we look deeper, then when we removed them, we were able to see thyroid and sternothyroid. So these are the two layers of the fascia also. The two muscles, sternohyoid muscle and the omohyoid muscle, will be enclosed in the superficial layer of the infrahyoid fascia of the muscular fascia, and the rest we are left with deep layer, that is sternothyroid. This will be in the deeper layer of the fascia. So these collectively is the infrahyoid fascia, and or otherwise known as muscular fascia. And I just discussed the two layers. It is unlikely that you may be asked in the exam, but it will help you understand the things better. If we move the fascia, if we follow the fascia, infrahyoid fascia above, it will be to the attachments of the muscle, and below to the attachments of the muscle. It is as simple as that. So below, the infrahead muscles are majorly inserting themselves into the sternum, sternohyoid, sternothyroid, and above it is attaching them to the majorly the due to the especially due to the deep layer to the thyroid cartilage and the hyoid bone above. So these are their attachments. Before I tell you, you may be already forming the spaces between them, but we will summarize them together, inshallah. Then there is a cervical fascia, the visceral fascia. It is easier to discuss the muscular fascia and the visceral. Remember the visceral fascia. The viscera are covering all the visceras. The three of them are being shown here: thyroid, parathyroid, esophagus, and trachea. If we are talking about the lower aspects of the neck, we will say esophagus and trachea, and if we are talking about the higher aspects, we will be talking about larynx and pharynx. These are further splits into three parts. The one that is purely enclosing the thyroid, the one shown in the blue here, this is known as pretracheal fascia. This is known as a pretracheal fascia because ultimately it is in front of the trachea. As you can see, due to the nature of the thyroid gland is like this. It is enclosing, covering the larynx, covering the trachea below behind it. So it is like this. So it is covering the three aspects. We are left with covering only the back aspect. To cover the back aspect, our Allah Almighty has given us the buccopharyngeal fascia. This buccopharyngeal fascia. So now Buccopharyngeal fascia along with the pretracheal fascia, it is now completely enclosing it. So buccopharyngeal fascia plus pretracheal fascia, they are together known as visceral fascia. I have gone into the detail because most of the atlas that you will view will be discussing it like this. However, most of the textbooks, because they don't want to overwhelm the student just like I have done right now, they mention all these by the pretracheal. In the Snell, most of you will be reading the Snell's reviews anatomy. You will discuss, read only one name, that is pretracheal fascia. But remember, in Snell's and some of the books, if the other fascia names are not given, this will be including the infrahyoid, the muscular fascia, and visceral fascia. That is where the uh, that is where the confusion arises. I've gone into detail because I have been asked by the students why the pretracheal fascia is covering the infrahyoid muscles, because when we are throwing a bigger umbrella in like then in Snell, the pretracheal fascia, it is including the muscular fascia and all the visceral fascia. So that is why there is a little confusion between the atlases and the text. So you must keep that in mind. So this is all about the pretracheal fascia, and especially when talking about the visceral layers, it will be along the viscerals, it will be along the vessels. The pretracheal fascia will move up to the with the trachea and to the larynx, and below it will move with the trachea and it will end at the great vessels, the aorta and the brachiocephalic veins. So these are about the fascias. Then we come to the prevertebral layer, the one shown in the orange. Let me open my book right here. Yes. Okay. A prevertebral layer. Prevertebral layer. The name says it is pre-vertebra. It is in front of the vertebra. So again, there is a little confusion, but you must keep both of these things in mind. Simply speaking, it is covering the vertebral column, the muscles, it is surrounding the vertebral column and the muscles moving the vertebral column. So it is enclosing it and it moves like a tube throughout the length of the vertebral column, and it is including the ligaments of the vertebral column, the muscles, and the nerves and arteries that are present there, including all the spinal nerves that are exiting from the nerves that are part of this area. So you may see the labeling of the spinal nerve right here. So all of the spinal nerves are present here. If the spinal nerves are exiting from here, it means that initial parts of the plexi will be formed here, the brachial plexus and so on. And a lot of arteries, initial part of the great vessels are present also here. Okay. So it is most prominent on the anterior aspect. That is why in some books the explanation limits to this part, the one that is anterior to the prevertebral group of muscles, that is posterior to the viscera and pharynx. And as we move to the lateral aspect, it becomes thinner and thinner, and the bag, it almost merges with the investing layer of deep cervical fascia, and it merges and you don't see it anymore almost. A very common question that is asked about the axillary sheath. As we said that spinal nerves are present right here, it forms the plexi, and when the plexi exits into the arm, it pulls this fascia along with it into the arm as the axillary fascia. So you must have answered this question when you were studying the upper limb, that axillary fascia comes from. The answer among the four wrong answer, the correct one is the prevertebral layer. So now you know it is prevertebral layer because the nerves are exiting from here, and when the axillary sheath, when the brachial plexus is to be formed, the nerves pull the sheath, pull the fascia to the axilla and form the axillary fascia. And here it also includes the artery, but keep in mind the axillary artery and the subclavian vein, and consequently the axillary artery is present within the axillary sheath, the axillary vein lies outside it. Okay, that leaves us with the attachments. uh, the attachments, again, I'm going again between the comparisons because the most commonly read books by the undergraduates are usually Snell's Clinical Anatomy and BD Jurassica, some high achievers, they aim for the grays also. So there are a little variation between the books. It all depends upon how they are defining it. If we limit our definition to the anterior aspect, if we limit our definition to the anterior aspect only, then if we follow the fascia up, it moves all the way up to the base of the skull. As we move back, there is a space between this fascia and the vertebral column. Here it is including all of the prevertebral group of muscles. That was longus colli and longus capitis we discussed yesterday. If we follow back, at the point when longus colli ends at T4, at that point the vertebral fascia, the prevertebral fascia, especially the anterior aspect, it fuses with the vertebral body. It is not very shown very clear here, but it will be here. If we see, that will be C7, and here will be T1, T2, T3, and T4. At this point, this fascia will fuse with the body here. I know this is going into the little detail, but it is become very important clinically. Why? Because as you can see, this anterior layer is fused to the sides tip of the transverse processes here. So the anteriorly this space becomes an independent compartment. Any pus, any fluid, any bleed that is included in this compartment cannot go beyond this point, cannot go beyond T4, because the anterior layer of anterior aspect of prevertebral fascia, it is attaching to the vertebral column. And again, here I have discussed in detail, because here a controversy arises and a self-contradiction is present in the Snell here, because when the Snell, it is mentioning the, it is not wrong, but it is a little explanation need for understanding. When it is talking about prevertebral fascia, it explains prevertebral fascia as a whole circle. But when talks about the prevertebral space, it only talks about, when it talks about the prevertebral fascia, then it says that it ends at T4. So the part that ends at T4 is only the anterior aspect. The rest of the circle is goes down all the way to the coccyx. So here the that is why the conflict arises, that when we say that prevertebral fascia surrounds all of the vertebral column, but in the next paragraph it is written that anterior margin, that the prevertebral fascia ends at the T4, it is because you're only talking about this anterior space, anterior aspect, and the same explanation goes for the prevertebral space. We will revise these things as we go to the this. So let's talk about the pretracheal fascia a little more. It is on the deeper aspect of the infrahyoid, the muscular facial layer, infrahyoid muscles, sternohyoid, sternothyroid, omohyoid, and it is enclosing the thyroid gland completely. Very important MCQ. Somehow it is very important MCQ, and historically speaking, we have seen it many times that pretracheal fascia encloses or trachea is enclosed by, and it goes on. So if we have discussed all of these things, we find, I think that slide is repeated. We discussed all of these here, but let me go through them again by text in front of you. When it's talking about pretracheal fascia here, I'm talking about all of these. I'm talking about infrahyoid superficial deep layers, pretracheal layer, and buccopharyngeal layer. And if we is the visceral and the muscular layer, visceral fascia, if we talk about it, above it is attachment to the, again the confusion again arises because we are not discussing them separately. Above it is limited to the attachment of the muscles, that is majorly the thyroid cartilage. Below it is attached, the visceral component is attached to the this great vessels, and the muscular components that goes and attached to the this sternum. Laterally it is limited by this carotid sheath. Now okay, let's wait for the spaces. I have, I'm just to give you at ease, prevertebral space, retropharyngeal space, we will be discussing the spaces shortly. So anything that is leaked into the space between the prevertebral space, pretracheal space, Let me take a deep breath. I know it is a little overwhelming for me too. Let's leave the spaces right here. We will discuss the spaces in the next section. Let me take a sip of water. I get a little emotional on this topic because I spent some time on, but I should not punish you for that. Let's keep things simple and move on. Carotid sheath. Carotid sheath is the one that is surrounding the carotid artery, common carotid artery, and the um, internal carotid artery and the other things. It is technically speaking not an independent fascia as we have discussed for the investing layer, for the prevertebral layer, and the cervical fascia. It is made by the condensation from each of the fascias from each side. On the medial aspect, it is by the pretracheal fascia, anteromedial aspect. On the lateral aspect, anterolateral and lateral aspect, it is by this investing layer of deep cervical fascia. On the posterior aspect, it is made by the prevertebral layer of fascia. It itself consists of only loose areolar tissues. You have to remember the contents. It is very important question. The contents. What are the contents? Talking about the arteries, the name is given in the name of the fascia, the carotid arteries. It includes the common carotid and internal carotid. External carotid is not included because as soon as the external carotid branches out, it moves outside the sheath. All of the great arteries, the common carotid, internal carotid, they have a plexus of sympathetic nerves around them that is included. Just lateral to the artery, there is a vein that is the internal jugular vein. In Urdu, which is Shahrab. And you have to remember this lateral relation that is very, very important because most of you going into the anesthesia and ICU and critical care and even internal medicine and nephrology, you will be passing cannulas into the internal jugular vein. So the relation becomes very important here. You palpate the carotid pulse and puncture laterally into the internal jugular vein. And between the two is the vagus nerve. In the upper part of the carotid sheath, other cervical nerves are also present that include the last four nerves, the 9, 10, 11, 12, glossopharyngeal, vagus, and not 10th, 11th, not accessory, and then it includes the, in the uppermost part, it may include accessory, but then hypoglossal nerves. So as we move down the carotid sheath, they exit, but the vagus nerves remain throughout. So it is usually written in the contents. But you have to remember that in the upper aspects, last 4, 9, 10, 11, 12 is present. And there are some lymphatics, the deep cervical lymph nodes, and the carotid artery contains carotid sinus and carotid bodies, and the nerve supplying them is also present here. Attachment above and below. Above, it follows the arteries up to the base of the skull, so it surrounds the openings from which the artery and the vein is coming from. So above, it is attached to the margins of carotid canal and the jugular fossa. And below, as moved down, it blends with the fascia of the great vessel that it is covering, that is majorly the aortic arch. So this is about the fascias. um, I like to go into the detail because it clears so many things up that are usually not covered if you skip this topic and try to understand them retrospectively. So the next one is the spaces. We will be talking about prevertebral space, retropharyngeal space, parapharyngeal space, submandibular space. Ignore the picture for now. Prevertebral space. When we are talking about prevertebral space, we are usually talking, especially the Snell and the undergrad books that we are reading, we are talking about the space on the anterior aspect, this space. We are not talking about whole of this space. Let's talk about this only. When for now on, when I'm talking about the prevertebral space, I will be talking about this. If we trace the prevertebral fascia upwards, it is attached all the way to the base of the skull. So the space, the upper end of the space, it will continue all the way up to the base of the skull. But if you follow down, we discussed it as the longest colli inserts at the level of T4, so does the prevertebral fascia. So this means there is a lower limit to this space, and that lower limit is T4. Do you remember this line? The line between the Do you remember the name of this line? The line that was anteriorly at the angle of Lewis and posteriorly, this is sternal angle भी कहते थे, and posteriorly it is at the disc between the T4 and T5. Can you mention in the comments if you remember this disc? So this was the demarcating line between the superior mediastinum and inferior mediastinum right here. That was further divided into anterior, middle and posterior. So in other words, we can say that this prevertebral space, it is in the neck region and it is limited to the superior mediastinum. So this is the thing to remember here, because this is the question that is asked, that any infection, that is inflammation, exudate that is present in the prevertebral space, it does not go beyond this point. It does not go beyond superior mediastinum. That is the very commonly asked question. Unless and until this fascia is ruptured, or what happens? Usually, like tuberculous meningitis, there was an inflammation of the vertebra, the bleeding, the pus started to ooze out. It started to ooze out in this space, and it will trickle down and move down to this point, and it will stop trickling down because it is fusing right here. It is not moving sideways because here is a connection at this point. And when the inflammation, the pressure becomes too high, it ruptures the fascia in front of it and it moves to the space in front of it. When it ruptures, is moved to the space in front of it, we will shortly see that it is known as retropharyngeal space. Now, uh, if you have understood and don't want to disturb your concepts anymore, put your fingers in your ear. But if you want to discuss one more controversy, I just want to tell you, because some books, even the Grays, Grays mentioned that prevertebral space includes this area also. Let me put it in a different color. Some book says that it includes this area also. So when just judge the context which you are reading. If the author has mentioned the whole of this space, then it will go down all the way to the vertebral column. But it is not usually not this case, and the books consider only the anterior aspect, so stick to that. Unless and until someone specifically explains this thing. Moving to the retropharyngeal space. The space that is in front of the prevertebral space and behind the visceral fascia, behind the buccopharyngeal fascia, behind the buccopharyngeal aspect of pretracheal fascia, this space is known as retropharyngeal space. This space. This is known as the retropharyngeal space. If we see up, there is another confusion right here. Here you may see an additional layer, right? This one, the orange one, the right here, drawn this one. This layer is called alar fascia. This layer is called alar fascia. So alar fascia is the one that arises. That's why I was opening my book. Alar fascia is the one that is coming from tip of the transverse process to the other tip of the transverse process, and it is running between the retropharyngeal space. So it is the alar fascia, and the retropharyngeal space, let's talk about it as a whole. Let's talk about it as a whole. If ignore the retroalar fascia just now, The retropharyngeal space will be present behind the visceral fascia in front of the prevertebral fascia, behind the visceral fascia, and it will move. If we move up, if we go to the base of the occiput, like you can see here, and any fluid, any bleed, anything that is present here will trickle down and go all the way down from the superior mediastinum to the posterior mediastinum, and it will be blocked only at the level of the diaphragm. So any inflammation, any exudate that is present in the retropharyngeal space, that goes all the way down to the diaphragm. So it includes superior mediastinum and posterior mediastinum. Now, one thing I want to say is here is the MCQ. So any fluid in the prevertebral fascia, prevertebral space, it's limited to the superior mediastinum. Any fluid into the vertebral in the retropharyngeal space, that will go down to the posterior mediastinum diaphragm. So this is the MCQ, and laterally it has extensions to the parapharyngeal space. We will go into the discussion a little more when we discuss the pharynx, but I will give you a little highlight. Now we were done with the basic. Let's confuse the things a little more. Let's go into the little detail. I'm going to the detail because different one you will be reading different books. Some of you will be reading for the part one BRS anatomy. Some of you will be reading Snell's, and there is a discrepancy between the books. So what is that? So the space, the fascia that we talked about earlier, this alar fascia that is between the two transverse processes. Let's follow the alar fascia. If you follow the alar fascia right here, you can see as we move down, it ultimately fuses with the buccopharyngeal fascia in front. It is not going all the way down. It is fusing with the buccopharyngeal fascia in front. So the part of the retropharyngeal space that was behind the alar fascia, the part that was behind the alar fascia, it goes all the way down. It is continuous with the posterior mediastinum. It goes all the way down. But the part of the retropharyngeal fascia that is in front of it, that is in front of it, that is limited right here. So in the books, you will read an other terminology. The part that is behind it, you will read the word danger space. You will read the word danger space. Don't confuse it with the danger triangle. Danger triangle was danger triangle, yeah, danger area, that was in the face where you are not allowed to burst your pimples, that will lead to the carotid sinus thrombosis. So don't confuse it with where that is the danger space. So these things occur when we are talking about the retropharyngeal abscess, and usually occur when you have very bad throat infection. The retropharyngeal lymph nodes become purulent, they leak out, and then they leak out here, and then you are asked the question, where will it drop down to? So that is about the retropharyngeal space. I don't have a separate slide for, okay, I have this slide, I will go through them here. Let's talk about what is submandibular space. It will be better explained after we have talked about the triangles. So just to give you immediately, to give you an overview, let me put a pin here. I will it will be too confusing to talk about it right now. Let's talk about it after triangles. If I forget, you are live, do remind me. I will move back to this slide. Let's talk about it then. Submandibular space, I'm speaking skipping them immediately. Well, let's talk about it when we have discussed the triangles. That why we talk about the triangle so much, why we talk about the fascia so much, because any infection is usually limited between the spaces. The infections, the inflammation, when even when not extreme, they don't cross the fascia into the next compartments. So that is why we need to know where can the, and within the fascia, it can spread very rapidly because there is nothing to stop it. Retropharyngeal space. Retropharyngeal space, it can go all the way down to the posterior mediastinum, to the inferior mediastinum. But you will find some books saying that it is limited to the superior mediastinum. So you have to keep your eyes open, you have to keep your mind open that which definition is being used. So sometimes it is written that retropharyngeal space, it is limited to the superior mediastinum. So when we're talking about that, we are only talking about the space anterior to the alar fascia. In those books, you will always read that the space infection, the danger space move all the way down. So in a general term, umbrella term, the retropharyngeal space will include both of these spaces. It will move all the way down. And if you are a picky anatomist, if you are a picky reader, and you are discussing the retropharyngeal space different anteriorly and danger space posteriorly, then the retropharyngeal space will be limited to the anterior fascia. Pretracheal infections, the infections that are on the front. It may be due to some external, and something may be due to an inflation from inside, maybe due to penetrating wound from the outside. When the infection is in front of the pretracheal fascia, again, the Snell causes a lot of confusion due to including both the muscular and the visceral components. In a common terms, when it is outside the muscular part, when it is superficial to the muscular part, it remains here. It remains in front of the muscles and it moves down and it ends at the level of sternum, because here the muscular fascia gets attached, investing layer gets attached, and the space is closed. But if the infection is between the muscular layer and the visceral layer, outside the visceral part, inside the muscular part, then it moves down, and as you can see in the superior mediastinum, that it will move to the inferior mediastinum in the anterior compartment. It will move to the anterior mediastinum. So this is how the infection spread downwards. I know this is a very cognitive overload. I know this is a little confusing for you right now. It may be confusing for you right now. I hope so. It is not. But the beauty of the online lectures is, beauty of the recorded lectures is, you can go and see only the parts that you get confused about. You can see them again and again. And do mention in the comments the questions you have. Do mention in the comments something I need to explain differently, or I can simply give you answers in the comment section. So do mention in the comments what queries do you have. Then we are left with prevertebral fascia. Prevertebral fascia, again, prevertebral fascia, behind prevertebral fascia, we are talking about the space only, this anterior space only. We are only talking about this space, and in the prevertebral fascia right now we are talking this prevertebral fascia only. Look, a cool dude with sunglasses. So anteriorly, if it's, let's talk about it superiorly and inferiorly. We don't talk about it expanded superiorly because gravity helps to trickle down. Inferiorly, it goes and it is limited to the superior mediastinum at T4, where it fuses with the insertion of the longus colli. Anteriorly, it owes to the retropharyngeal space only after rupture. There is no actual pathway, but this is such a close space, such a high tension is built that it ruptures the fascia in front of it and it moves to the retropharyngeal space, and it now becomes a retropharyngeal infection. Laterally, it can go beyond this point. Laterally, it can go into this space, and laterally, it goes through the axillary fascia to the upper limb also, to the axilla also. So this is the fascia. This is the inspections of the neck. I'm skipping it right now. Inshallah, when we will discuss submandibular space, we will discuss this also. So this is a brief summary of the cervical fascia. What's the time right now? I have 11:57. let's take a 5 minutes break. I'm leaving with you with this slide. If you have the questions, queries regarding this, mention in the chat right now. After the break, inshallah, I will answer your queries and move on with the next topic. The next topic is the triangles of the neck. So I'm leaving you with this slide. So let's take a 5 minutes break. I think it's 11 almost, so 12 almost. So I'll rejoin at this. See you after this. Let me get a few things straight. Okay. It's 12:05 with me. Let's start with the next topic. The next topic is triangles of the neck. Triangles of the neck. Here in this particular section, I will be discussing how each of the triangle is formed. The other way of saying is what are the boundaries of each of the triangles. Then we will discuss what are the components present inside them. I will not be going into the very detail of each of the components, but let's focus about the triangles. First of all, the whole of the neck. On the back, the neck is covered with the trapezius muscle. It's a very broad muscle we discussed in the last lecture. So, in front of it, the neck, all the neck that is in front of the trapezius, it is divided. This part, it is divided into two triangles by this muscle. This is called sternocleidomastoid muscle, the muscle that runs from mastoid process all the way to this process. So this is called let me get a few things straight. Yes, so this is the whole of the sternocleidomastoid. The part that is anterior to it will be the anterior triangle. The part that is posterior to it, it is called the posterior triangle. I would encourage you to do is through the pictures, it would remain longer with you, it will last longer, and you won't have to memorize the other things. So let's see how the anterior triangle is being formed. It is labeled in the green right here. So the anterior triangle on the upper aspect, it is by the jaw. The lower margin of the mandible, it is forming the upper boundary of the triangle. Posteriorly, by sternocleidomastoid. Which border of sternocleidomastoid? Anterior border of sternocleidomastoid. And superiorly, posteriorly, superiorly mandible, posteriorly sternocleidomastoid. Then we are left anteriorly. There is no very prominent anatomical structure that defines it. Simply the midline, the sagittal plane, the midline that you can draw on the skin, that will be the anterior limb. So this is the anterior triangle. Superiorly there is mandible, posteriorly there is sternocleidomastoid, medially or anteriorly, because the neck is curved for the part, the most medial part is the most anterior part also, that is the midline. Posterior triangle, the part that is under the cover of sternocleidomastoid, is not considered a part of either of the triangles. You will see in written in the books that cervical plexus, it's not a part of the triangles because it is under the cover of sternocleidomastoid. Let's move to the back. This whole area, this whole area, this is the posterior triangle. Anteriorly covered by the posterior margin of the sternocleidomastoid, posteriorly by the trapezius, and inferiorly by the clavicle, middle one third, the part which had the supraclavicular space. Okay. So anteriorly there is posterior boundary of sternocleidomastoid, posteriorly there is anterior boundary of trapezius, inferiorly there is middle one third of the clavicle, and on the top there is the apex. It is no boundary, it is by the skull, base of the skull. It is the anterior triangle is further divided into four parts. The posterior triangle, it's divided into two parts. Let's leave it like that. Let's start with the anterior triangle. This is a picture from later, looking like this. Remove the skin. So anterior triangle, anterior triangle is bounded by midline, anteriorly or medially, jaw, lower margin of mandible, superiorly. Some books say supralaterally because it's up and lateral. Posteriorly, and some books says laterally because when we're going posteriorly, you're also going laterally. It is said lateral, it is said posterior, it is said posterolateral, and even infralateral word is also used because it's inferiorly and laterally. So this border, the lateral border, it's made up of anterior margin of sternocleidomastoid. Let us see how it is divided into four further joints, four further triangles. Before going into that, Identify the muscles that you did last day. This muscle is digastric. This is the anterior belly. This is the posterior belly. Behind it, this point, this is the mylohyoid muscle. This horizontally running bone is the hyoid bone. This muscle that goes from the hyoid bone to the sternum, that is sternohyoid. This muscle that goes here, moves through the sling and goes here. This is called omohyoid. The part that is present here is the superior belly. The part that is present here is the inferior belly. And of course, we are left with sternocleidomastoid. So let's see how they take part. These are the muscles, especially keep in mind that digastric, anterior and posterior bellies, omohyoid, superior and inferior belly. These will be the major muscles playing the part. So this is the first triangle, submental triangle. You can see how it is being formed. Laterally by the anterior belly of digastric muscle, posteriorly by the hyoid bone, body of the hyoid bone, and medially simply the midline. So this is submental triangle. This is submandibular triangle because it is present below the mandible. It is present below the mandibular fossa, below the submandibular gland. It is called you see submandibular gland is present right here. It is having three boundaries. The medial one will be the anterior belly of digastric. Posterolateral one will be the posterior belly of digastric. The anterolateral one will be the inferior margin of the mandible. So these are the three triangles. This is called submandibular triangle. The alternate name is digastric triangle because almost whole of it is being covered by the two sides are covered by the digastric muscle. The alternate name is submandibular. Alternate name is submandibular triangle. Then the next one, this is carotid triangle. As you can see, it is having carotid vessels in it, internal carotid and common carotid. So it is made up of superiorly. You can see that thus there is digastric and styloid muscles, and anteriorly there is omohyoid, superior belly of omohyoid, and posterolaterally there is anterior margin of sternocleidomastoid. Muscular triangle. It has two lateral borders, supralateral, infralateral, and one medial border. Supralateral border is formed by the superior belly of omohyoid. Infralateral is made up of sternocleidomastoid, and medial one is made up of midline. So these are the three borders of the four triangles that are being made by the anterior triangle. There are two key muscles that are doing all of this work, that is digastric, two bellies, and superior belly of omohyoid. And of course, there is midline here. So these are the contents. Before moving into the contents, let me show you this picture. If you're reading Snell, you will see this picture. Submental triangle between the midline, hyoid bone, and the anterior belly of digastric. Submandibular triangle, digastric triangle between the margin of the jaw, anterior belly, and posterior belly of digastric. Carotid triangle present between the posterior belly of digastric, superior belly of omohyoid, and the sternocleidomastoid. And we are left with muscular triangle. It is present between the superior belly of omohyoid, sternocleidomastoid, and the midline. Of course, the upper peak is being made by the hyoid bone also. So these are the structures that are forming the four triangles of the neck. But right now, I will just say to memorize the things, but I can try a little to the submental triangle. Submental triangle, this area, it contains the lymph nodes of the same name, submental lymph nodes. It will contain submental lymph nodes, and It will contain some mental lymph nodes, and there will be some internal jugular veins that are present here. Submandibular triangle, digastric triangle. This is okay. Here is the submandibular triangle. Below it, there is a submandibular space that I skipped earlier. I will go to it just after this. It contains, as we see by the name, the submandibular gland, and the lymph nodes present here have the same names. And the facial artery, the facial nerves move through this. Then you can see in the base, in the floor, there is mylohyoid muscle. So the nerve to mylohyoid, the mylohyoid vessels that are supplying this, they move through here. And for a little part, the hypoglossal nerve comes in this aspect also. We will discuss this, we will discuss the tongue. Then there is a carotid triangle. Immediately, if you don't think of anything, just think of uh, the contents of the carotid sheath, the carotid sheath itself and its contents. Common carotid artery, internal carotid artery, external carotid artery, all of its branches, all of the branches. There are 8 branches of external carotid artery. One branch is excluded here. Just remember this name. All of the branches of external carotid artery except posterior auricular. Then there is lingual, facial, all the other arteries, the lingual facial veins. You will memorize these vessels inshallah tomorrow when we discuss the branches, the arterial tree and the venous branches, venous tributaries. And then there is hypoglossal nerve, the part of the ansa cervicalis and the lymph nodes. Muscular triangle, just remember the digestive tract, the respiratory tract and the viscera in front of it. So the digestive tract will include larynx above, trachea below. The digestive tract will include pharynx above, esophagus below. You must have remembered from the uh, you must remember from the thorax that between the two, the trachea and esophagus, there is always running of the recurrent laryngeal nerve. This will be the part of it. And in front of this, there is an organ that is present, that is the thyroid gland. Thyroid gland and just behind it parathyroid gland. So these are the structures that are formed in the middle, so the muscular triangle. So we are trying in the muscular triangle. Then there is a posterior triangle. Posterior triangle have two important questions. First, the boundaries. Overall, the posterior triangle has anteriorly sternocleidomastoid, posteriorly it has trapezius, and inferiorly clavicle. If you want to fill more pages, go into more detail. Anteriorly, it has the posterior border of sternocleidomastoid. Posteriorly, it has anterior border of trapezius. Inferiorly, has middle part of the clavicle. These are the boundaries. Then the question arises about the floor of the um, posterior triangle. This is a very important question, commonly asked, especially in the vivals. Which structures are forming the floor? Just stick to the labeling. The first muscle, the most commonly, splenius capitis, then levator scapulae, then scalenus medius. These are the muscles that you must remember. They are very visible here. The one whose only margins are seen, these include semispinalis on the top, and on the bottom end you may see scalenus anterior. You see how difficult it is to see them. And you may see first slip of serratus anterior. You may see the first slip of serratus anterior. So these are all of the muscles that are forming the floor of the posterior triangle. If I go from all of them, semispinalis, splenius capitis, levator scapulae, scalenus medius, scalenus anterior, and if you are extending the neck and you are doing too much of the effort, you may see the serratus anterior. Now, let's talk about the breakage of the triangle into two contents. The posterior triangle, just like the anterior triangle, was broken up into 4 triangles. The posterior triangle is broken up into 2 triangles. the upper one and the lower one, and the thing that divides them, it's this is the inferior belly of omohyoid. Inferior belly of omohyoid. So the triangle that is above it, that is the occipital triangle, I have highlighted for you, and the one that is below it, it's the supraclavicular triangle. And even if I don't tell you, you can pick up by the image the boundaries of them. The occipital triangle will have sternocleidomastoid, trapezius, and inferior belly of omohyoid, and the supraclavicular triangle will have sternocleidomastoid, inferior belly of omohyoid, and middle third of the clavicle. So these are the posterior triangle. Contents are numerous, and I won't be helping you very much in memorizing it. But let me tell you how do I remember it. I go system wise. Let's go to the arteries first. Arteries include subclavian artery. Subclavian artery, it contains the last part of the subclavian artery and second and third part. Basically, it contains the third part of the subclavian artery, and it will have a few of its branches, that is supraclavicular, dorsoscapular, if said. Then there is subclavian vein. Of course, if there is artery, there will be vein. And there is external jugular vein. External jugular vein moves like this, and it goes to the back and it dips right here. And here it goes inside the deep fascia and it merges with the internal jugular vein. So external jugular vein is here. Then there are saw the um, cutaneous nerves. So these are also here. You saw the cutaneous nerves emerging from right here. The one that was going front of it, the transverse cervical, the one that were going below, the supraclavicular, the one that is going up, the greater auricular, and the one that is going to the back, lesser occipital. So all of these will be the branches, will be the components of this posterior occipital triangle. Then another important nerve that is supplying the two major muscles here. You are supplying the, you see the sternocleidomastoid in front and trapezius at the back. Then there is a nerve that move like this. From it is inside sternocleidomastoid. It emerges from the sternocleidomastoid, goes to the back and inserts into the trapezius. So that will be accessory nerve. So, and of course, if we're talking whole of the posterior triangle, inferior belly of omohyoid will be one of its contents. Posterior, the deep cervical lymph nodes, the posterior aspect, there will be some nodes on this aspects also. And so these are the things that will be present here. So let's see if we have skipped someone. There will be occipital artery, branch of external carotid that will goes back, the transverse cervical, suprascapular, and subclavian arteries. Occipital is a branch of external carotid artery, not a branch of subclavian, but these are branches of subclavian. Transverse cervical, suprascapular, external jugular veins, accessory nerves, cervical plexus branches, brachial plexus trunk. Brachial plexus is seen a little here between scalenus medius and scalenus anterior. Here is the boundary of scalenus anterior, here is the scalenus medius. So you will see brachial plexus exiting from here and going behind into the axillary region. So this is about that posterior triangle. Before moving into the cervical plexus, let me fulfill the promise that I made before about the submandibular space. So I skipped it before, submandibular space. So simply speaking, it is the space that is enclosed by the submandibular triangle, that is enclosed by the submandibular digastric triangle. So space is it was two-dimensional, triangle is two-dimensional. So you need third dimension. So below it will be covered with investing layer of deep cervical fascia. Above it will be by the mylohyoid muscle, floor of the mouth. So this is all the extents. So superiorly above it will have the mylohyoid. You see, so this is the submandibular space right here. This one, the little one right here. Here will be the submandibular space. Above, the upper and lower margins will include, above it will be the mylohyoid muscle, below it will be the investing layer of deep cervical fascia. So this is the submandibular area. So it is shown right here. Below is the investing layer, above is the mylohyoid. So this is the submandibular area. Superiorly, mylohyoid, inferiorly. If you go all the way to the skin, you will go through investing layer, superficial fascia, and the superficial fascia, including the platysma, and you will go to the skin. And then the three borders will be the three borders of the triangle. Anterolateral will be the mandible. Anteromedial will be the anterior belly of the digastric. Posteriorly, there will be the posterior belly of the digastric and hyoid bone. So there will be plus posterior belly. So this is the space. So if you move at the neck, you can touch it right here. This is the submandibular space. Okay. It contains, what are the contents that it contains? I will be, I don't have the picture right now. Let me get the picture. Mm, give me just a second. Just give me, okay. Let me change the view a little. I have too many balls in the air. Okay, let's see like this. Yes, this is a picture from Gray's Anatomy, Gray's Atlas. So here you can see, okay, here you can see the posterior, here you can see the mylohyoid muscle and the posterior margin of mylohyoid muscle. This is the mylohyoid muscle. And if we move to the picture below, you can see the submandibular gland. We will go into the glands a little more detail as we go into the oral cavity. So this submandibular gland, it winds around the mylohyoid muscle and come to the top of it. See, here is the mylohyoid muscle. Submandibular gland is below it. It moves around and on top of it to the sublingual space. So the point I'm trying to make is the submandibular space that is below the mylohyoid muscle. It curves around the posterior margin and comes to the top of the sublingual space. So the submandibular and sublingual space are in connection with one another behind the posterior border of mylohyoid. Submandibular space contains the submandibular gland itself, the lymphatics and nodes by the same name. There is facial artery, facial nerve, part of lingual artery, hypoglossal muscle under a little bit passes through it, and that's it. So that's about the different infections. I'm not going into the much detail of the sublingual space. It is present above the mylohyoid muscle and below the mucosa of the tongue. Just keep this particular point in mind, and then we will discuss it when we will discuss the oral cavity. So the infection of the submandibular space is known as Ludwig's angina. It is known as Ludwig's angina, and Ludwig's angina, it may go behind and above into the sublingual space. And usually, why does it occur? Let me get to again the atlas again. Okay, um, to the atlas again. Yes. If we look at the atlas, you may see that the mylohyoid line is oblique. So the line of attachment of the mylohyoid muscle, posteriorly it is higher, anteriorly it is lower. So the roots of the teeth, the root of the molar of the posterior ones are related to the submandibular space, and the anterior ones are related to sublingual space. The posterior roots go beyond, the anterior roots stay above. So the extraction of these teeth, if there is an infection of the roots, and this infection, it goes through the bone into the spaces, they may come into the sublingual space and submandibular space. For the teeth that are in the back, that is the molar teeth, they may lead to the infection of the submandibular space, that is Ludwig's angina. So the injury of the oral mucosa, it will give infection to the sublingual space, some prick that happened, and it goes to that. Below the mylohyoid line to the submandibular space, above the mylohyoid line, anterior bones, premolars, it will sublingual space. So that's all about the triangles and the spaces and fascia. I'm taking just little break. What's the time with me? I have 12:30. Let me give a 2 minute break. After that, we will continue with the nerves. Two nerves, set of nerves, we will be discussing cervical plexus and the and the sympathetic chain. So let's take a 2 minute break. Okay, let's move on to the last part, the nerves. Dividing into two parts, the cervical plexus, and then we will be discussing the sympathetic chain. Just like you discussed this, you know about the plexi present in the rest of the body. In the upper limb, we talked about the brachial plexus. In the lower limb, there was lumbar and sacral plexus. Similarly, there is a one for the cervical region. It is the root value. It is coming from the anterior MI C1, C2, C3, and C4. They are mostly coming from this. C5 onwards is part of brachial plexus. The other part is their location in terms of muscles. It is between anterior and middle scalene. It is between two scalene muscles, anterior and middle scalene muscles. So it is anterior to the middle and posterior to the anterior scalenus muscle. The fact that it is coming from anterior rami, that is true for all plexus. That is true for all plexi. Then there is a talk about the ansa cervicalis. We will go into the little more detail here. There is a loop hanging down that is having the anterior downcoming limb, posterior upgoing limb, not upcoming downgoing, but anterior limb and posterior limb. This is the ansa cervicalis. We will talk more about it in just as we follow the other branches, and it supplies majorly the muscles of the neck, this cervical plexus as a whole. Ansa cervicalis majorly supplies the infrahyoid muscles. That are four muscles that are present there. Let's see the branches. The cervical plexus, it has, first let me show you through the back picture again. If you notice, this is the nerve, that is hypoglossal nerve, going through the head and neck, going to the tongue. As the C1 fibers branches from the brachial plexus, they exit, and you may not see the C1 branches going elsewhere. C1 branches are just entering the hypoglossal nerve. So they are not distributed by themselves. They get into the hypoglossal nerve and get a piggyback ride into the different regions. It goes through the hypoglossal nerve to the genioglossus, goes through the hypoglossal nerve to the thyroglossus, and even the anterior ramus, that is supplying the infrahyoid muscles. So the anterior limb of the ansa cervicalis, that is supplying the infrahyoid muscles, that exits through the hypoglossal nerve. So when talking about the hypoglossal nerve in the cranial nerves lectures, you may come across the sentences like hypoglossal nerve supplies the genioglossus and thyroglossus muscles. Hypoglossal nerve supplies the infrahyoid muscles through anterior limb of ansa cervicalis. Just keep this thing in mind that all of these supplies, these are from actually from C1. Nothing will happen to these muscle if there is isolated damage of the hypoglossal nerve nucleus in the brainstem. So, and it is very wonderfully, beautifully shown by this picture of netter hair through this red line. So, this is about the ulcer cervicalis. This is the branch, C1 branch that is going to C1. It becomes a part of hypoglossal nerve to the two muscles, genioglossus, hypoglossal, and the superior root, the anterior root of the ulcer cervicalis. It is coming from hypoglossal nerve. And this is, and then we are left with the posterior inferior root of the ansa cervicalis. It is coming from two nerves, two roots, C1 and C2. They join, and then they form the inferior posterior root of the ansa cervicalis, and this go on to supply the infrahyoid muscles. Then there are the muscular branches. We are done with the infrahyoid muscles, the front of the muscles in the front. Then the muscles are left with the prevertebral muscles, anterior group and lateral group. Anterior group included the longissimus coli, longus capitis, and rectus capitis anterioris, lectus capitis lateralis, and on the lateral aspect there were scalenis anterior medius later. All of these muscles are supplied by cervical plexus. Their branches are not shown here, but direct branches from the cervical plexus, the anterior ramus, they direct branches go to the nerves. Their direct branches go to the and direct branches go to the those muscles. And so even if you have reading the original insertion tables of Snell and KLM, you are reading the tables, you won't see the named nerves. You will just see the C1, C2, C3, C4 as they are supplying the segmental nerves. Then there is phrenic nerve. That is a bigger one and important one. It is shown right here. You may say they have taken care to make the C4 root larger as compared to the C5 and C3. C5 and C3 are giving the minor roots, and the major contribution is coming from C4, and it will go down. Very important MCQ point, that it runs anterior to the scalenis anterior muscle. It is on the way, it is embedded in which fascia? Prevertebral. It is embedded in the prevertebral fascia, and it moves down anterior to the subclavian artery, and it moves down all the way down to the thorax, and the rest of the supply and the root will be discussed in the thorax lectures. Then the sensory nerves. The four main sensory nerves that have been discussed in the previous lecture with the neck, skin of the neck, and they have been discussed in the this today's lecture while talking about the relations, when talking about the contents of the posterior triangle, and when talking about the posterior relations of the sternocleidomastoid. So these were the four muscles, nerves. So there was two going upwards, one going horizontally, one going down. The one going downwards, the supraclavicular nerve coming from C3 and C4. They will further divide into medial, intermediate, and lateral branches. Medial one will go all the way to the midline at the angle of Louis. Intermediate over the pectoralis special up to the rib 2. Lateral one will go into the lateral aspect and back of the shoulders over deltoid muscle, upper half of the muscles, and on the back up to the level of spinoscapula. Then there is transverse cervical nerve. It goes transversely in this direction, superficial to the sternocleidomastoid, to the anterior of the neck, and it will supply this whole area from the chin all the way to the jugular notch. These are the supraclavicular nerve. These are the transverse cervical nerve, chin to manubrium. And then we are left with what? The nerve that are going upward direction. These are two, lesser occipital and greater auricular. Lesser occipital will be the one that emerges from the tip of the posterior triangle, and it will go at the back of the ear all the way to this area. So it will supply the skin behind the ear and the skin on the medial aspect of the external pinna. Greater auricular will, on the other hand, this is sternocleidomastoid. On the posterior part of the sternocleidomastoid, this will emerge from here and it will cross sternocleidomastoid and come to the angle of the mandible here. So it will supply this area and it will supply the lower half of the ear, lateral surface of the pinna and part of the external auditory meatus all the way up to the eardrum also. So this is the greater auricular nerve. Then there are sensory nerves that are not so much in not so much high stakes, but you have to know them. For topic anatomy, we will discuss everything. These are the meningeal branches. They will go up into the posterior cranial fossa and give it supply. You may have a memory of reading about them when talking about the meninges, the meningeal supply of the posterior cranial fossa. It was supplied by the cervical branches C1, C2, C3. It was supplied by the cervical plexus. So how do they go up? Some of them, especially C2, C3, they go by themselves. The branches, they go directly through foramen magnum into the posterior cranial fossa and supply them. Otherwise, they may get a ride from hypoglossal nerve in the case of C1 or the vagus nerve C2 and C3. Those nerves are coming down, so these fibers will go in upward. They will go along the nerves and they go up and get in the posterior cranial fossa below the tentorium cerebelli and supply these areas. Then there are proprioceptive fibers. If you remember from the yesterday's lecture, we discussed the origin, insertion, and supply and functions of sternocleidomastoid and trapezius. If you remember the table from the Snell in which the origin insertion was written, those the nerve was written accessory nerve, spinal root of accessory nerve, and branches from the cervical plexus and branches from C2, C3. So these are those branches. Those are not technically motor branches. These are basically sensory branches. The proprioceptive signals coming from sternocleidomastoid and trapezius, they don't go to the CNS along with their own nerve. They don't go to the CNS along with spinal accessory nerve. They go to the CNS through independent nerves that are from the cervical plexus, proprioceptive branches from C2 and C3, C4 and C5, C3 and C4. Not shown in this particular picture. They may have some motor fibers because it has been noted that after even the sectioning of complete sectioning of accessory nerve in some people, there may be some motor movement present here. So this is due to this proprioceptive branches. So this is about the cervical plexus. Let's move on. It's a relatively difficult topic and a very disliked topic, and it is left at the end. We will do at the end of the end. So this is that topic. So sympathetic chain, sympathetic trunk in the head and neck. So sympathetic trunk, before talking about the actual placement and branches of the sympathetic chain in the head, let's talk about a little about the autonomic nervous system in general and the sympathetic chain. Let's a little general anatomy. In any sensory system, there is a single neuron connection between the receptor and the central nervous system. There is always cell body in the dorsal root ganglion, and a single axon goes all the way peripheral axon, peripheral part of the axon, and then central part goes the central nervous system. There is no break. There is a similar situation with all the motor somatic motor fibers. There is a cell body in the central nervous system. In spinal cords, it is in the anterior horn. In brainstem, it is present in the motor nuclei. And the axon exits and run all the way to the muscles. Skeletal muscle, there is no interruption between. However, the autonomic nervous system, be it the sympathetic or the parasympathetic, it has a very unique arrangement. it has two nerves from the central nervous system to the effector organs. The cell body of the first neuron is always present inside the CNS, may it be brainstem or spinal cord, and the cell body is of the second neuron is present outside the CNS in the ganglion. We will see about the different ganglia. So the first cell body, the preganglionic presynaptic cell body is present in the CNS. The axon exits, come to outside, and it synapses with the cell body of the second neuron, that is postsynaptic postsympathetic neuron cell body. I will not be using the word second for now. This postsynaptic neuron cell body, it gives rise to an axon that ultimately postsynaptic postganglionic axon goes and affect the effector organs. So the autonomic nervous system consists of two parts, sympathetic and parasympathetic. This is the thing that you have been reading about even before entering into the medical field, even before in the O levels, A levels, and your FSC metric. So the sympathetic nervous system is the one that helps you in the fight or flight. So remember, think about all the things that are happening. Respiratory rate is increasing, heart rate is increasing, sweating is coming, pupils are dilating, the hunger vanishes, the peristalsis goes away, you forget about going to the washroom, sphincters the close very tightly, and the peripheral and the all the blood is pumped toward the muscles to make them ready. The parasympathetic nervous system goes the opposite way. It is rest and digest. When you relax, your heart rate cools down, your respiratory rate falls down, body temperature comes down, peristalsis activity start. It gives you a feel of hunger. There's a salivation, glandular activity occur, sphincters open up. You need to void yourself. You need to relieve yourself. So that's what's happening. What's the difference between the system in anatomical terms from where they are originating? So you may take a screenshot. Behind me is all the, I'm a little hiding the functions of it. I will not be talking about the functions. You may take a screenshot for it right now. I will be talking about the anatomical aspect, the origin of it. The parasympathetic fibers, the parasympathetic fibers, the rest and digest, they are originating either from the brainstem or the sacral segments of the spinal cord. So it is originating from brainstem and sacral segments. So its origin is called brainstem, and sacral segment, its origin is called craniosacral. You should know the actual origin. In the brainstem, it is coming as the component of 4 of the 12 cranial nerves, that is 3, 7, 9, 10, oculomotor, facial, glossopharyngeal, and vagus nerves. Then these contains the fibers of the parasympathetic fiber, and consequently you can understand that they have the nuclei that are giving rise to those fibers. Those nuclei are the presynaptic parasympathetic fibers. For example, in case of in case of oculomotor, there is Edinger-Westphal nucleus. So in the sacral segment, it is coming from the nuclei present in the segments S3, S2, and S4. S2, S3, S4. So they are giving rise to the presynaptic fiber. They are coming outside. Parasympathetic fibers that are coming outside. Presynaptic. So that's enough about parasympathetic. Let's get to our main topic, sympathetic. You can see from here, the sympathetic fibers are coming only from the thoracic segment and the lumbar segment. They are coming from the thoracic segment and the lumbar segment. So its origin is called thoracolumbar output. This origin is strictly speaking coming from segment number T1 to segment number L2. So thoracolumbar segment. Let's dive into a little more detail. We're talking now only about this thoracolumbar segment. So we're talking about only sympathetic. So sympathetic will be present in T1 to L2. So all this talk will be applicable to T1 to L2. Here, the presynaptic sympathetic cell body, it is present in the lateral horn. It is present in the lateral horn. From the lateral horn, the axon originates. The axon exits through the anterior ramus, exits through the anterior root, ventral root, and ventral root, it comes to the spinal nerve. it is a very common sense that it has to somehow reach the sympathetic chain. It is for now in the spinal nerve, it has to reach the sympathetic chain. So the connection that helps us reach the sympathetic chain, this connection is known as white ramus communicantes. This is called white ramus communicantes. And by then white, you may get the idea that these presynaptic fibers are actually myelinated. That are actually myelinated. They come, they come into the sympathetic chain, and here they will find the post synaptic or ganglionic cell body. Here was the presynaptic ganglionic cell body. Okay, here is the end of the presynaptic axon. It synapses and transmits the signal to the postsynaptic ganglion, and here the story starts from this neuron. This has to go back to the spinal nerve. It has to go back to the spinal nerve to supply the erector pili muscle and the sweat glands that it has to supply. It the it does not go back the same route. It has too much of a self-respect and ego. It has its own track. It has its own connection. That connection is called gray ramus communicantes. That connection is called gray ramus communicantes, and gray ramus tells you that it is unmyelinated. That is unmyelinated. So by this information, it goes back to the effector, and the effector may be the skeletal muscle arteries, they may be erector pili muscles, they may be sweat glands, and so on. So this is about the major simplistic pathway, the simplistic route. Now, one thing I want to tell you here, this point of information can give you an point of MCQs also. You will have an MCQ about where the presynaptic ganglion are present, T1 to L2, where are they present in uh, lateral horn, what are the type of fiber, myelinated, how do they go to the sympathetic chain through white ramus communicantes, then starts with gray ramus. Gray ramus is unmyelinated, with the which one is lateral of the two, white ramus is lateral, gray ramus is medial, and so on. These questions can be asked. So white ramus will only be made due to preganglionic. Preganglionic will only come where there is output. So white ramus communicantes will present only in T1 to L2 segments. However, the gray ramus will be present in all C1 to coccygeal segments, all 33. Okay, so this is about that. So this is a little summary of other things. This is a picture from Gray's Anatomy. So these postsynaptic neuron, these postsynaptic cell bodies, they make up this ganglion, this chain. This chain, that long chain that forms on either side of the vertebra is called sympathetic trunk, sympathetic chain. It consists of about 3 cervical ganglions. These are called superior, middle, inferior. We will be discussing in detail. Then there will be 12 thoracic ganglion, then there will be 5 lumbar, 5 sacral, and ultimately 1 coccygeal from each side. They will join in the midline to form ganglion impar. The inferior thoracic ganglion fuses with the inferior cervical ganglion fuses with the first thoracic ganglion to join to form stellate ganglion. And this is it, we will discuss it again. And there is a little variation between the numbers that is not universal, and it is due to the fusion or separation of the ganglia. And this actually is the case in the neck region, because the cervical region is actually the fusion of what was supposed to be 1, 2, 3, 4 ganglions that have fused to form the first superior cervical, then the next two, and the next two. As we talked about, the white ramus communicantes will be present only where there is a sympathetic output. They will be present only in the L1, T1 to L2. Gray ramus, however, will be present throughout. Synaptic preganglion and ganglion, so we have discussed that. So once we discussed the very simplistic arrangement, how the preganglionic reaches the sympathetic chain. It was cell body present in lateral horn and exits through ventral root, spinal nerve, white ramus communicantis, and sympathetic chain. Now it has reached the sympathetic chain. One fate we discussed that it synapse exits back with the gray ramus and so on. But there are about three fates, three we can group them together. There can be more if we go into the further detail. One thing is that when they have reached the sympathetic chain, they immediately synapse at the same level, and then after the synapse, the postganglionic exits. Second situation, when the egg enters, they may move up and down the sympathetic chain, and they will exit from there. The third option is they may not synapse at all. Let's go into the detail. This was the first one, the one that we saw in the previous example. There was presynaptic sympathetic ganglion in the lateral horn, exits through the anterior root, comes to the spinal nerve, reaches the sympathetic chain through the white ramus, and here it synapses with the cell body shown by the circle here at my pointer, and its axon, unmyelinated axon, go through the gray ramus communicantis into the spinal nerve, and through it, it will be disseminated in different parts. What about these segments? There is no inflow to this part of the sympathetic chain, the cervical ports. There is no inflow to the lower lumbar and sacral part of the sympathetic chain. How are they getting the presympathetic fibers? So, for these, this makes the way. The entering preganglionic fiber, it may go up the sympathetic, it does not synapse immediately, and it starts climbing up. It goes up the sympathetic chain. Or in the lower regions, in lumbar regions, it may enter through the sympathetic chain through the same pathway, but without synapsing, it may move down to the other region. In the lower regions or in the upper regions, after changing the level, it may synapse, and after it may synapse and go to the gray ramus communicantis into the spinal nerve and supply the arterium. The same is true for the upper region, same is true for the lower regions. Here you can see the visual representation of the things about the two rami. From L1 to T1 to L2, where there is an outflow, there are both ramus. There is white ramus communicantis and there is gray ramus communicantis. For input, white ramus; for output, gray ramus. For the others, in the cervical region and in the lumbar region, there is only gray ramus communicantis, because it does have a postganglionic fiber getting out into the spinal nerve, but it does not have a preganglionic fiber coming in. The preganglionic fibers are coming by moving up and down the sympathetic chain. So this is about the pathways. This is the level changing. A little bit for going into the more complex, it may synapse early and then change the level. Also, this may also occur, but leave it for that. Then there is the ones that exit without synapsing. There are four nerves made from this. You must have read it in the abdomen pelvic region. These are greater splanchnic, lesser splanchnic, least splanchnic. And the fourth one is lumbar splanchnic. The preganglionic reaches the sympathetic chain through the same pathway, but there, without synapsing, it exits and come out of the sympathetic chain, and it is now preganglionic and myelinated, and it will remain preganglionic all the way when it reaches the celiac or renal, simply speaking, pre-aortic nodes, celiac ganglion, and here it will synapse and give rise to the, in celiac and superior mesenteric, inferior mesenteric, it will give rise to the postsynaptic fibers that will move along the arteries of the gut. So these are splanchnic. You must have remembered the branch or root values. T5 to T9, they form the greater splanchnic. T10, 11 form the lesser, 12 form the least, and L1 and L2. This is usually forgotten because we are so busy with greater, lesser, least splanchnic that it goes to the These are the preganglionic splanchnic fibers, and they can be seen right here. They independent nerves, and they move. They penetrate the crust of the diaphragm and they go down. Postsynaptic sympathetic fibers, all the rest of the viscera, the fibers that are going to the esophagus, stomach, the esophagus, heart, and lungs, trachea. These are also known as splanchnic nerves, but those are not preganglionic splanchnic nerves that, right, like we discussed before. These are postganglionic splanchnic nerves. So the point of telling you this was, if you read about the cardiac splanchnic nerves, don't say that immediately it is preganglionic just on the basis of greater splanchlet and lesser splanchnic nerves. Talking about the sensory fibers from the viscera. So the sensory fibers from the viscera, the information from the gut, the information from the heart, it travels back through the along the spinal nerves, along the sympathetic nerves that were supplying them, and when it comes back with the sympathetic nerves, it follows the same route. It with the sympathetic nerves, it reaches the sympathetic chain, and from the sympathetic chain, it goes to the spinal nerve via white ramus communicantis. ये बात भी याद रखनी है. You have to remember this, that the sensory nerve, they re-enter the spinal cord via white ramus communicantis, and this will explain so many things to you, like heart. Heart is being supplied by a sympathetic chain from the superior cervical ganglion also. So the superior cervical ganglion has connection to the C2, C3, C4, C1, but you feel the referred pain only starting from T1 because the white ramus communicated it started at T1. So that is why the visceral pain, referred pain, you may not in the normal, in the every situations, you won't read about them beyond T1 to L2. Even the abdominal region, appendix, cecum, descending colon, you will read about from T1 to L2. So, about discussing all of this, we come to the conclusion that what the structures are making sympathetic chain. It was consisting of presynaptic fibers, it was consisting of postsynaptic sympathetic fibers, and of course, the cell body of the postsynaptic neuron. And in addition to that, visceral afferent fibers traveling along the sympathetic fibers on the way to the dorsal root ganglion, they do cross the sympathetic chain. In addition to that, there will be supporting cells. We can discuss more in the histology. There is will be for the myelination and for the covering of Schwann cells for the myelination, and stellate cells for covering of the cell bodies. Let's get to the actual topic. It was a very big preamble. That's the beauty of the recorded lectures. You may have skipped to move to the cervical sympathetic chain. Um, it is in the thorax. It is from the base of the skull to the thoracic inlet, first rib, and it is medial to the highest intercostal vein. And that's something about the relations. I have not shown a picture here. Let's move to the ganglion actual. There are three ganglions. The largest one is the superior cervical ganglion, then there is middle and inferior. The superior cervical ganglion is present very near to the vertebral artery, medial to the vertebral artery, and it is lying in front of the prevertebral fascia. The prevertebral fascia, um, the one that was in front of the longus colli and the scalenus anterior. Let me change a lot of slides immediately. Yes, here you saw that sympathetic chain was lying in front of the prevertebral fascia. So it's lying outside the prevertebral space. It is lying in front of the prevertebral fascia. And it is medial to the vagus nerve. There is a vagus nerve, and it ends in the superior cervical ganglions. Okay, this is a sympathetic chain. Let's talk about ganglions one by one. Ganglion 1, superior cervical ganglion, it is present in front of the cervical transverse processes C2 and C3. Here it is present. Middle cervical ganglion, it is present at the level of C6 transfer process. It is shown here. Behind it, palpable, it's the Cassagnac tubercle, carotid tubercle, and it is related to the inferior thyroid artery right here. And the third one is the inferior cervical ganglion. It is present in front of the first rib, and it is behind the initial originating part of the vertebral artery. So there is one thing that is ulnar subclavia. The sympathetic chain connects the superior with middle, middle with inferior, and so on with all of them. However, the connection between the superior, middle, and the inferior, it is not simple chain. The chain is split into two. Some part of the fibers they loop around the subclavian artery and goes to the inferior ganglion, the stellate ganglion. Here it is a little more visible. So it moves as like this in front of the subclavian artery into the inferior ganglion, cervical ganglion. This is known as ansa subclavia. This is an anatomical picture. You can take a screenshot here. Right now, stellate ganglion. It is to emphasize that a single person may have stellate ganglion on one side and separate inferior cervical and T1 ganglion on the opposite side. Let's talk about the branches, C1 branches, C2 and so superior and middle and inferior. First, Grere muscommunicatus. It arises from the lateral aspect and it supplies applying from the lateral aspect and supplies C1, C2, C3, C4, and these will supply the postganglionic sympathetic fibers to area of supply of these dermatomes. Second, cranial nerve branches. Some nerves they join the vagus nerve, glossopharyngeal nerve, and hypoglossal nerve. These joining nerves they become a part of pharyngeal plexus. So, when talking about the pharyngeal plexus in the head and neck region, you may read that vagus nerve supplies the sympathetic fibers to the pharyngeal plexus. So, it is not actually that vagus nerve is sympathetic. It's simply that these fibers are getting a piggyback ride. They are getting a ride to the pharyngeal plexus. There may be direct branches going to the pharyngeal plexus also. And the direct branches may split the carotid body. The carotid body was shown, I think it was shown, I don't remember it now. Okay, um, yes, the carotid body and sinus. The carotid body and sinus, the carotid body was the chemoreceptor of the arterial blood and carotid sinus was the baroreceptor of the arterial blood. We will discuss them tomorrow, inshallah. And then there are arterial branches, the branches that are going along with the internal carotid and external carotid artery, the plexus, sympathetic plexus that is formed around these arteries, the branches are coming from superior cervical ganglion. And then each of the three cervical ganglion give a cardiac branch, and the one from the superior cervical ganglion is called superior cardiac branch. Then there is middle cervical ganglion. Middle cervical ganglion, it's present behind the at the level of C6. It supplies C5 and C6. The Grere communicantis gives rise to the arterial branches to the inferior thyroid artery. You might have remembered that it was very closely related to the inferior thyroid artery. So it gives a nerve plexus to the inferior thyroid artery that leaches the thyroid gland. And the last one, the cardiac branch, the middle cardiac branch, that is from the largest one. And then there are also branches going to the trachea and esophagus. Just remember the cardiac, trachea, and esophageal branches may be labeled as splanchnic, but they are sympathetic, but they are postsynaptic. Inferior cervical ganglion is the largest one, is the not the largest one, it's the lowest one, more inferiorly. It is fused with the first thoracic to form stellate ganglion, and it supplies the branches of C7 to C8, and it gives arterial branches to the subclavian artery, and from it to its branches that include the vertebral artery and so on. And these will go to the also give rise to the cardiac plexus, deep branches of the cardiac plexus. You may get it by now that the middle and inferior cervical ganglion they are supplying C5, C6, C7, C8, and if joined with the first thoracic T1, they are supplying the brachial plexus. Cardiac nerves are three in number. They go to the superficial and deep cardiac plexus, and this cardiac plexus is present right here under the arch of aorta, in front and to the right of the ligamentum arteriosum, in front of the pulmonary arteries. So this is the cardiac plexus, and these are all branches coming from the three cervical, up superior, middle, inferior, and the branches to the thoracic plexus is coming from the thoracic segments. Also, we will discuss that in thorax. Horner syndrome. What if the sympathetic chain stop giving the outflowing signals? It may be interruption at the brainstem level. There will be higher, there will be brainstem lesion, cervical segment lesion. They may affect it, and in the later syndromes you talk about Horner syndrome. Later medullary syndrome is one of the examples. Thyroid carcinoma, Pancoast tumor of the apex of the lung, and penetrating injury, they may directly affect the sympathetic chain that is running on each side of the vertebral column. And even the cervical vertebra, cervical rib, that may cause a traction on the that will cause a traction on the rib to make it. What are the symptoms? Symptoms, it's the upper eyelid drops down because sympathetic supply to the levator palpebrae superioris is lost. So there is ptosis. The sympathetic to the sweat glands is lost. There is no sweating. There is anhidrosis. There is loss of supply to the dilator of the pupillary muscles. So there will be constriction of the pupil, that is known as meiosis. And due to the meiosis and dropping of the eyelid, the eye seemingly feels like the eyeball has sunken deep into the eye socket. That is called enophthalmosis. There is another possible explanation for that. There is a muscle called orbitalis in the inferior orbital fissure that is supplied by sympathetic fiber. If that is not functioning, the eyeball goes a little back also physically. So these are the features: ptosis, meiosis, and hydrosis in ophthalmosis. Stellate ganglion block may be done for some therapeutic and diagnostic regions, especially if there is an oversympathetic drive or some visceral sensations coming through this pathway through the sympathetic chain are causing more pain. So in of these cases, there is a block of the sympathetic chain. To get to the sympathetic chain, remember the Chesapeake triangle. That chain was running in front of it. So needle is inserted at the level of carotid tubercle and it directed behind and inferiorly and medially until it reaches the sympathetic chain. And then there is sympathetic arterial insufficiency of the upper limb. Some people have overdrive of the sympathetic system and they have a very high flow of the sympathetic impulses to the upper limb. That troubles them in the way that their arteries remain in the state of constriction, and whenever they have to do some physical work, their blood is not compensated and they have pain and they have issues. So what is happening is that actually the fibers that are going into the upper limb, the nerve fibers of the upper limb was sympathetic chain. The nerve fibers of the upper limb was brachial plexus. Just remember, in the previous slide, you studied that the upper limb, the sympathetic, the brachial plexus was being supplied by middle cervical ganglion and stellate ganglion. So even if the fibers supplying the upper limb are exiting through T2 to T8, they have to climb up the chain. They have to reach the T1 and stellate ganglion at the inferior end. If they are separate, the T1, first thoracic, inferior cervical, and the middle cervical ganglion, and from there they have to go to the C5 to T1. So what to do is not to if we just damage the sympathetic chain, we are at a verge of we will create Horner syndrome. So we can't simply break the sympathetic chain. So what we do that we break the connection between T1 and T2. So even the outflow tract is reaching the sympathetic chain right here. It does not reach the it climbs up and is interrupted right here, maybe by cutting, maybe by clipping, and it does not go up. And when it does not go up, it cannot go into the brachial plexus by greater micromanigantis of C5 to T1. So the sympathetic supply of the upper limb is interrupted. At the same time, most of the outflow for the head and neck is coming from thoracic outflow. So T1 is intact, and the fibers will go up, and the Horner syndrome will be avoided. So this is about the clipping. So thank you for listening. Today's lecture, most of the pictures are from Netter's anatomy and Gray's Atlas of Anatomy. One of them, or one or few of them, was from the Snell's Clinical Anatomy by Regents. I did not discuss almost anything on the 3D model. So let's keep it for tomorrow, inshallah. I was using otherwise 3D4 complete anatomy by 3D4 medical by elsewhere. So thank you so much for listening. Thank you so much for being online with us. If you have any queries, questions, and suggestions, please drop down in the comments below. Inshallah, I will try my level best to answer these. See you next time, inshallah. Allah Hafiz.